I think that's been a bigger lesson in being open about when you miss something, because it has to be a learning or opportunity. Otherwise, it was a worthless experience.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, welcome back to the podcast. I'm Kevin McFarland, your host, and welcome to the Art of Emergency Nursing. My guest today is a former Army officer and ER nurse who shares a lot of her tough experiences that she learned the hard way, but shares them with you, so hopefully you don't have to. There's a lot of lessons to be learned in this episode, so pay close attention. You're going to enjoy this podcast with my friend, Sarah Miller. All right. So first, what I'm going to do, Sarah, is ask you to introduce yourself, tell the audience a little bit about your background, a little bit about what you do, and how long you've been a nurse.
Okay. So my name is Sarah Miller. I've been a registered nurse for 16 years. I started my career as an Army Nurse Corps officer. So my first year of nursing I spent in Iraq. So I was a baby nurse deployed to Iraq. After that, I have spent all my time in the ER. And then the last 5 years, I think, I have moved over into more of a supervisory management role, in which it's a 50% charge nurse and 50% administrative role, where I am the assistant nurse manager in a small emergency department. We're 12 main ED beds with a small 4-bed fast track and a 4-bed OBS unit. So that's kind of where I'm at right now as far as my career.
Nice. Well, Iraq had to be a tough place to be a baby nurse. Holy cow. I can't even imagine how intense that training had to be.
So it was a little scary because, that was my first nursing experience. I had never even been on the floor since nursing school.
Wow.
But the good thing about it is there's not really time to be scared. You just got to do it. And there's an amazing amount of examples around you of experienced nurses and a lot of experienced medics who know so much. And I honestly feel like that's where I got a lot of my hands-on experience with a lot of my seasoned NCOs and enlisted who gave me my hands-on skills that I did not gain in my bachelor's program. Just being able to start IVs and drop NGs and all that stuff came directly from them and observing them. And they were excellent teachers. And so much opportunity to do things and not enough time to be scared. And you just did it. So
it's funny how that works. It's probably a lot like the ED sometimes. You don't have time to think about it. Just go.
Yes, exactly.
So at what point in your career were you like, okay, I made the right choice. This is exactly what I'm supposed to be doing with my life, is being a nurse?
I mean, even ever since I was a little kid, I always knew I wanted to do something in the health profession.
Mm-hmm.
And of course, as a kid, I thought I wanted to be a doctor. And then I realized there's something better than being a doctor. I could be a nurse. I think honestly, it was probably in my deployment to Iraq, not right away, because I was still a little like, oh my gosh, I'm not good at this. We were nearing the end of our deployment in Iraq, and they did a small award ceremony that was hosted by the infantry unit that we were supporting. In the military, those things are very scripted. So my unit, my medical unit, told the infantry unit, these are the people that did these things, and you should give them awards. And usually it's the lower enlisted or whatever, so that they can build their resumes and stuff like that.
Yeah. And
it was done, and we're all kind of just standing around. The formal scripted part was done, and their senior leadership, I think he was a full-bird colonel, pointed in my direction, and he said, "You, LT." And I turned around and looked over my shoulder, because, I'm surrounded by LTs. There's a ton of us. And I said, I just kind of look around. He's like, "No, you, the blonde one," because he couldn't see my name tape.
Mm-hmm.
And I said, "Me?" And he said, "Yes, you, come here." And I'm like, "Okay." And he goes, "I don't know your name." He's like, "Nobody knows your name." He's like, "But all I ever do is see you work." And he's like, "But I see you all the time. And you're always there when I come in, and you're always working. and you always have your hands on my shoulders, and I am so grateful for you. And he's like, I couldn't get your name from anybody, but I see your face and I know who you are. And he said, I remember you from every mass towel and every time I brought one of my boys in, and you were always there. And I want you to know that I am grateful to you.
That's awesome.
And all I got out of it was a coffee cup with their infantry logo on it, but that thing means the world to me. And I knew at that moment, this is where I was supposed to be.
That's super, super cool.
So
that's awesome.
That was it.
It's nice. It's nice when somebody notices the hustle.
Yeah, exactly. So.
That's cool. That's super cool. It's a great story. Tell me about a patient who changed the way you practice.
So I feel like a lot of my stories are going to be from Iraq. But
that's fine. That's if that's where your career was shaped, then that makes a lot of sense.
There's a lot of learning that first year.
I bet.
So being a young and ambitious lieutenant who was dying to be in the ER but not quite ready, I was charged to run the walking wounded during mass cal situations. So, but keep in mind, when we deployed, I deployed in 2004, so the very beginning of the war almost. It was a quick ramp up for my unit. There wasn't a lot of extra training, so I got to my unit just in time to do our live fire exercises, get your deployment gear, and get on the plane and go to Iraq.
Holy cow.
There was not time for me to get extra medical training. So I went to Iraq with only what I learned from my bachelor's program. I did not get TNCC. I didn't even have ACLS at that time. I was green. So walking wounded, usually no big deal. These guys, scrapes, flesh wounds, nothing too exciting. But this was close to the end of our deployment and things were starting to ramp up in country. And some of the stuff had gotten a little smarter. They had started cutting off our supply chain. So we were very short on supplies, meaning IV tubing didn't always have ports for injection. We only had 18 gauge needles for injection. Just little stuff like that. Just things were really basic. So there was a bombing and we took a very large amount of casualties in a very short period of time, like 30 minutes. And this was our worst mass cal situation at this point. My room, which was normally reserved for walking wounded, turned into a second ER because we could not house all of the injured in our main ED. And there were too many to leave outside because we were already at this point stacking bodies at the back door. Mm-hmm. So in my room, because I had this very large, just open room, there was a wall of gurneys, and then it's just like a mass of people everywhere. And there's not even a patient charge. So it's kind of like on Pearl Harbor. We had Sharpies and you were writing on patients' chests and foreheads what you did.
Wow.
Because there was no place to write. Paper would be lost. So you wrote on their body. So I'm going around, and luckily very blessed with super high-speed medics who took very good care of me and our patients. And I'm making my rounds, seeing every patient, and I get to this young guy. And I said, what's going on? And his blouse had been cut off, so he's just laying there in a T-shirt, and I could see blood on his shirt, but it wasn't a huge excessive amount, and he's awake and alert, and he's talking to me. He said, ma'am, I took some shrapnel, but I'm doing okay. And I pulled up his shirt, and I could see some small, little flesh wounds on his side, but nothing that made me super excited.
Yeah.
And he looked pretty good. I moved on down the line. See all my patients. And then I feel one of my medics tap on my shoulder, and she said, ma'am, I need you to come back and see this guy. I think you missed something. So I go back.
That's got to be the worst feeling ever.
Yeah. And it's the same guy, and he's still awake, but his mental status has changed. He's now pale. And his abdomen is now distended and firm. And I roll him, and I see that he has shrapnel entry from the back.
Oh, shit.
That I didn't know, because I, at that time, was not trauma trained. I didn't know you were supposed to roll your patients. So I missed it.
Wow.
And so I run down, And I get my senior doc, and I say, hey, I need to get this guy in the OR now. Like, he's got shrapnel in his abdomen. I think he's perked his bowel. Like, I need your help. Our OR was overwhelmed at this point. So we put him on a helicopter, and we flew him to another combat support hospital where he received surgery. I didn't know his name, so I couldn't do any follow-up. I don't know what happened. So that's the face you see, all the time. But from that, it changed my practice, and I sought out opportunities to learn how to care for trauma patients. And I'm very open about talking to other nurses about that situation, because if I'm ashamed of that, because I'm embarrassed. I'm not embarrassed, but like, gosh, what could be different if I had known? But I make sure that everybody that works with me knows better, because they won't make that mistake. And that's
absolutely.
I think that's been a bigger lesson in being open about when you miss something, because it has to be a learning or opportunity. Otherwise, it was a worthless experience.
Right.
So.
Yeah, I think that's one of the things one of my goals with this podcast is give people the opportunity to learn from other people's mistakes. Because holy cow, like, if we could take the nursing knowledge collective and say, okay, don't do this and do more of this.
Yeah.
We can maybe avoid a pothole or two for somebody else. Now that's a win.
Yes, absolutely.
Even in the face of, something that's bad, something bad that happens.
Mm-hmm. For sure.
So, holy cow. That's a pretty incredible lesson to learn.
Yeah.
So, that's the kind of thing you only do once.
Yeah. Yep, for sure.
Tell me about your first medication error.
My first medication error. It was a Toradol Zofran mix-up.
Oh, really?
Yeah. I was busy, and the doc ordered 15 of Toradol and 4 of Zofran. And I inadvertently drew up 30 of Toradol and 2 of Zofran.
Ew.
And gave the patient a double dose of Toradol. And I'm assuming the doc ordered because the patient was kind of small. But luckily, they had a good creatinine clearance and all was well. But that was my first mistake. And oh my gosh, I wanted to just melt into the floor. I was so embarrassed. And I think it was just a mistake born out of just you get into that habit of these drugs are harmless, no big deal.
Yeah.
And I do this every day, and I give these drugs so frequently that it's just this no-brainer, instead of stopping and thinking and being careful about what I was doing. Having to talk to the doctor and everything was just kind of ugh. We have new systems in place that make medication errors infrequent, but and I'd like to say that was my last one, but I'm sure it's not.
Tell me about your last one.
My last one, let's see, I'm trying to think, what was my last one? My last one was when we had this patient come in, and he was symptomatic bradycardia, but he was also having an MI. He was 90.
Holy.
Yeah. So we get him in the gurney, and we've got him on the Zoll pads, and I've got my ED attending, I've got the cardiology fellow, the cardiology resident, and the ambulance guy standing behind me, and everybody's talking, blah, 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 blah. And, and the resident's pacing the dude without even talking to me. So there's a lot going on that is just going over my head, because nobody's being the clear point person.
Clear leader of the code.
Exactly.
I hate it when that happens.
And I don't even remember. I think, so we started him on Levocet, I think. And I was getting 2 conflicting starting doses.
Uh-huh.
So I went with what my ED attending told me. And the pump allowed me to do it, so I assumed that it was acceptable. I can't remember what the dose was at this time. And the patient did fine, but the cardiologist was very mad at me because that was not an appropriate dose, she said. And that was my last. And I don't know if that I would consider that an error versus like a miscommunication, but I felt like it was an error because the cardiologist was quite upset with me because she said it was too high of a dose. Even though his pressure wasn't through the roof, the guy wasn't doing bad. I was like, okay, sorry. Next time, then you need to be more clear that you're in charge, okay? That was the last time, and that was actually just like a month ago that happened.
Holy cow!
Yeah.
One of the things that's hard is when you're. I know. I've seen it specifically in teaching institutions when you're dealing with residents and attendings and multiple attendings. Boy, it's hard to say, unless there's a really structured process for saying this person leads until this point, then this person leads. You end up having too many chiefs and not enough Indians. You have 5-6 people barking orders at one nurse who's trying to do it all.
Yeah. But
and you're like, okay, one person, one order at a time.
Yeah. And that's what it is difficult because like, unless they introduce themselves, I don't always know who you are. I know who my attending is, and pretty much everybody else is just a blur to me. So I'm generally going to follow my attending's direction in this instance because I know them and I trust them. And if you don't like what they said, maybe you should talk to them. But I felt bad, and I always tell my nurses that like, you go with your ED attending because that's what's going to cover you. But I felt bad because I don't want to do anything that would harm my patient. And that's what I felt like she was telling me I was doing. And so that was kind of hard to take.
Yeah.
So,
yeah.
Anyway.
Tell me about a patient who touched your heart.
Oh, come on, Kevin. You know I don't have a heart.
Oh, I know you have a heart. And I know it's deep in there and it's probably cold.
Very cold.
But what do you got? I'm sure someone's touched your heart.
Mm-hmm.
I mean, I know where you work. There's heartbreaking cases there every day.
Yeah.
Who got through your tough exterior?
So this is a weird one, and this one might even surprise you, actually. So everybody that kind of knows me that like the alcoholic and the mental health patient is not necessarily my forte. I generally get to play the role of bad cop with those types of patients. It's pretty good role for me. I do it pretty well.
You go with your strengths.
Exactly. And so that's what I play to on that one.
What are you going to do?
Right?
What are you going to do? Yeah.
But there's this one gentleman, and because of where I work, frequent visits from the same people, and you get to know them pretty well. And I know this happens at most facilities, but being at a VA, you get to know them a little bit more personally, I think.
I think you're right.
This particular gentleman, I think he's schizophrenic, and he has an alcohol problem. And most of our staff don't like him, honestly, because he's not very pleasant to them. But for some reason, he is attached to me, and he says the nicest things to me. I mean, not like that's what makes me feel for him, but like he'll come in and he's generally, he'll be sober for a little bit, and then he'll fall off the wagon, and he'll be very intoxicated, and he'll show up in the ER, and he'll be sobbing, and he's crying because his mom and his brother have passed away, and he has no family left. And he just repeats over and over, it should be me. That they were worthwhile people, and I am not. And he just cries and cries. And I honestly can't even put my thumb on what it is about him that just gets to me. But I can never bring myself to play bad cop with him. I always have a soft spot for him. I always bend over backwards to make sure he gets fed, that he has clothes, that we give him every opportunity to sober up, to go to recovery if he can. He usually gets admitted because he withdraws very hard. And then he has to be restarted on his psych meds and everything. But I cannot get him out of my head. And I hadn't seen him for a while. And then I got a call, and it was from him, and it was sent to the hospital because, of course, thank goodness he doesn't know where I live. But
thank goodness,
right? But he finally moved out of state, and he was letting me know that he'd been sober for I think he said 6 months, and then he's doing well, but he still remembers me, and that he was grateful for how I was being nice to him. And it's just, I always remember his face. I always remember his story, and I don't know. He's just the one that gets to me for some reason.
That's cool.
Yeah.
That's really cool. Like, you have a heart after
I know.
Who knew?
Don't tell anybody.
I'm totally not going to edit this out just so we have the evidence. What's the best advice a nurse mentor ever gave you?
I think the best advice I ever got was, don't ever be afraid to ask a question. And don't ever be afraid to teach. So basically, don't ever be afraid to be the student or the teacher, whatever the case needs. And I feel like that's something that's benefited me for a long, long time. And even now, as I further my education and I try to help grow the nurses that I work with, is that it's never okay to not ask. You can always ask me anything, and I don't care what it is. Ask me, and we'll figure it out. But when you just kind of go off on your own and don't ask the question, that's when you're going to get in trouble.
Absolutely.
And I feel like the times that I was afraid to ask is when I always got in trouble. So it's always better to even just feel 1 minute of, I feel dumb asking this question, versus making a mistake or being in your superior's office explaining why you didn't ask and did it anyway.
Yeah.
It's just simple. I know it's a simple thing, but it's something I've always kind of tried to stick to. And I feel like it's benefited me.
That's pretty good advice. Mm. What's the worst advice a nurse mentor ever gave you?
I think the worst advice I ever got, and I preface this with, I think that what they were trying to say was good, but how it came out to me didn't come out right, was that you need to do without thinking.
Huh?
And yeah. And I understand that there's some situations in which you do need to be so ready and just prepared that you are just, it's like muscle memory. But that doesn't mean that you aren't thinking. It just means that your body knows what to do, and your brain is just working so fast that you don't have to work through each motion. But I don't think there's ever an instance where you are not thinking, and there should never be an instance when you aren't thinking. So that one, yeah, that was kind of like, huh? What are you getting at with that? Because I don't think that means what you think it means. So
you're like, wait, I get the idea, but I think you're missing the point.
Right. Yeah. And I really mulled that one over for a while because I was pretty young when I heard that. I'm pretty sure that was like Iraq. And I think they were trying to say that into trauma situations and mass house situations. And
yeah, like a just go,
yeah,
just work.
And as I figured things out, I figured out that she meant you just need to be prepared and trained up enough that this is not something where you sit there on go for so long and being scared and
Absolutely.
let your brain work. But it's certainly, I don't feel like there's ever a moment where I don't think, because I think all doctors and nurses will tell you that every situation you have to be thinking through all of the
Constantly.
scenarios and everything that could go wrong and everything that could go right and what we are doing and what we should be doing. And yeah, your brain is always swirling during every situation, I think. So.
Right.
Yeah.
Yeah, no, I totally agree with that. I think that it's constant.
Yeah.
So it's constant. You're just constantly going, okay, what next? And thinking a couple steps ahead.
Yeah. Sure.
So,
yes.
Yeah. So I know one of the things you do in your role is hire new nurses.
Mm-hmm.
What do you look for when you're looking to hire a new nurse in the emergency department?
I guess for me, what I'm looking for is someone that is excited. It sounds bad. It sounds kind of conceited, but I guess like I'm looking for a little bit of like a little me. What I remember of myself when I came into the emergency room, being like so excited because this was all I ever wanted. Like I knew that this was the place for Sarah because she did not fit anywhere else. But the ER was my home. I guess I'm just looking for somebody with that kind of excitement and excitement to learn and get all these new opportunities to do all these new exciting things, but honest about what they don't know, but looking forward to learning it all and jumping at the chances to learn those things and putting themselves out there to say, hey, I don't know this. Can you please show me? Those are the types of people I'm looking for because you don't have to know everything. And I think that's the key is admitting you don't know, but being open to learning and excited about doing it. And I think that's a lot of the big key to success. I think that's what I'm looking for in a new nurse anyway.
Nice. Yeah, I agree. So much is just that attitude. And
Mm-hmm.
like the I want to be a sponge and I want to learn as much as I can. I'll take those people all day long.
Absolutely. Yeah.
So, you mentioned that the ER was your home. How did you know the ER was your home? So you were a brand new nurse, just finished nursing school. How did you know the ER was what you wanted to do?
So throughout nursing school, so I went to school in South Dakota State University. And I don't know about other nursing schools, how it went, but I know certainly 16 years ago, when I was in school, you didn't get to go to the ER part of your clinicals as that was just not done because new nurses didn't go to the ER. That was not done. So me wanting to be an ER nurse, I was already being cautioned that that's like 5 years down the road. So clinical every day, being in like med surg and mother baby and even the ICU, I was like, man, I think I made the wrong choice. Like, this is not for me. I am super unhappy. I feel really out of place. I just didn't feel right. I just felt like I was really not suited for those areas. And I finally begged my instructor, and she gave me one clinical shift in the ER. And I went down there, and we saw, just general stuff, because it's South Dakota, it's rural. It's not like excitement everywhere. That day wasn't super exciting.
Yeah.
I saw a kid with an appy, and I got to start a couple IVs. And then as it was nearing my end of my clinical shift, they had flown in this young lady from the reservation. She had taken a bunch of pills, washed it down with a bottle of Jack because she found out that she was HIV positive. So she was trying to kill herself.
Oh.
Yeah.
Oh.
So at that time, we still did gastric lavage. We still did charcoal. So I'm in there. I've got my little plastic gown on with my little white nursey uniform, right? And we're shoving that charcoal down, and she just vomits it everywhere. And I'm covered in charcoal vomit. And you know what?
No.
Yes, everywhere, all over my little white uniform. And they're all like, oh, my gosh. And in my heart, I was like, oh, my God, I feel amazing. This is where I want to be. And it's the most ridiculous thing, but it was. It was just like oh, my God, this is my home. This is what I want. I love the chaos. I love the change. I love these moments of just like people's best and worst and just being right there. and getting to be part of it. And it's just amazing because like here she was, and this was like the most tragic moment of her life. And we are doing these things. And while she may not understand that we're helping her, and she may never thank us, it doesn't matter. You're still there and you're still doing it. It was so exciting. And I still get excited when I think about it because it was just that moment when I knew this was it. This was for me. I didn't love anything else but the ER. And this was all I wanted. And
that's awesome.
My clinical instructor saw me when I got done. She's like, oh my gosh, now do you see why we don't do this? I said, no, you're so wrong.
You're like, no, this was best day ever.
Right?
Like covered in charcoal puke.
Right?
Oh God.
And I'm so thrilled. I had to throw all that stuff away, but it was just the best moment.
That's funny.
Yeah. That's
funny. That's cool.
Yeah.
What advice would you give a new nurse starting in the emergency department?
You know, it's funny. I just gave this advice to someone the other day who is not necessarily a new nurse, but someone that I think would have benefited from hearing this from early on that I heard as well. And it just kind of happens for me. Identify with someone that you admire their practice,
Absolutely.
admire their nursing skill, and that you feel safe talking with. And you don't have to be formal about things, but, you know, identify with a mentor. And I had that for the first at least 5 years of my nursing career. Just somebody that I could always go to and ask all my questions, maybe bounce patients off of them and be like, would you have done this differently? How do you feel? Would you do that? I really feel like that was a huge part of growing my confidence and my skill and my professional practice by just identifying somebody that I wanted to emulate and to grow up and be like, for that lack of a better way to say it. I just feel like a mentor is a huge part of making good nurses, and also for us as more experienced nurses, it's a good way to impart what you know and feel good about what you're still doing. Even if you're not at the bedside all the time like I am now, I'm still a little pulled back from the bedside. It's still a way to grow the next and make sure that we're growing good and not just growing.
Yeah.
So,
you know, one of the things there's a paramedic that made a comment, and there was, someone talking about how they had 20 years experience. And he said, you need to ask yourself the question. He goes, do you really have 20 years experience, or do you have 1 year experience that you've repeated 20 times?
Yep.
Because it's not the same thing.
Mm-hmm.
And I was like, that's deep.
Yeah.
That's some deep. That's
right?
That's some deep thinking right there.
Mm-hmm.
But it's absolutely true, because how many people have the same experience year after year after year, never grow.
Right.
They don't learn.
Yeah.
They don't have somebody to mentor them and kind of guide them in their way.
Mm-hmm.
And they just kind of muddle along their practice.
Mm-hmm.
And, if everyone's lucky, hopefully they don't kill anybody.
Exactly.
And don't do less harm, do more harm than good.
Yeah.
But unless you really develop and you really are learning stuff, that's what really makes a difference.
Yeah.
To me.
For sure. And it's definitely got to be somebody you trust, because you can't keep going to this person if they're not helping you. But
it's because it's hard to be vulnerable to somebody in the professional realm and be like, dude, let me get your advice, because I may have screwed this up.
Yeah. Yeah, exactly.
That takes a lot to be vulnerable like that, and it's not easy to do.
Mm-hmm.
It's not easy for people to do. It's not easy for people to open up and be like, okay, I really don't know what I'm doing, so let me talk to you a little bit.
Right. But I think if you can open yourself up like that, you definitely open yourself up to really expanding and benefiting your practice and just making yourself a better nurse.
Absolutely.
So.
What advice would you give those mentors, those people who are being watched? What advice would you give them?
I guess what I would say is to be grateful for the opportunity and look at it as an opportunity, that you're getting this chance to shape a nurse and make them into someone, make them into somebody that you want to work with. Make them into the provider that you're excited to go to work with, because you know that they are excited about what they do. They're educated, they're a go-getter, they're a hard worker. It's something that was ingrained from the military is lead from the front, lead by example, and always do what you expect others to do. So if I'm asking you to do this task, know that I will always do it with you, that I would never do it. I would never expect you to do something I won't do myself. And just show and demonstrate and really just be that nurse. Like, I guess I just want to be that nurse that other nurses want to be like, so that they're looking to you and wanting you to be their mentor. And I feel like that's an exciting thing. And it's like a total pat on the back. And you should feel that way when they come to you.
Totally.
Yeah, like I'm identifying you because you're a rock star. And I think we should take it as a compliment and see it as an opportunity instead of like, oh my God, now I have to do more work. No, man, this is an opportunity to make your life better, to make your floor better,
Absolutely.
to make everything better, and to see it that way and invest in the next generation of nurse, I guess.
Absolutely. I agree 100%. The last question I have is a question I ask everybody, and it's a question called 3 things. So I'm going to ask you for 3 things a new nurse should remember and 3 things a new nurse should forget.
Oh, gosh. Okay.
It's a tough one.
Okay. So 3 things a nurse should remember. I guess for me, these are things that I had to learn. So I think it's important. 1, leave it at the door. Don't take it home with you. Whatever happens there, it's got to stay there because it can affect your personal life if you don't learn to leave it at the door.
God, it's hard though.
It's very hard. And it took me a very long time to adapt that skill. And luckily for me, I'll be honest, that's something I could pick up in Iraq, because if you did not leave it, even just at the hospital, when I walked back to go to sleep, you weren't sleeping. And you became crazy. So you've got to find your way to leave it at the door, whether it's go for a run, do yoga, read a book, whatever you have to do to leave it at the door so that you can have a normal life when you go home. 2, I would have to say, never forget to learn, to continue to learn, and to seek out opportunities to learn. So learning is always there. You're never done being a student. I remember when my teacher said that, and I was like, I hate you. It's true.
I'm in grad school. It's not what I want to hear. Exactly. It's what you were thinking, wasn't it?
But yeah, it's so true, because nursing and medicine is always changing, and it's super exciting to be at the cusp of that. So take these opportunities to be learning and bringing the newest to your colleagues. Just, learn something new, because there's always going to be something new that you don't know. And it can be fun and exciting to know the new things that are going on. So always learn.
Absolutely.
Last thing. I guess I would have to say, I don't know how to put this. I guess support each other as a profession. Nurses are notorious for eating each other's young. We eat our young. And it still goes on, unfortunately. I think it's important to grow each other. You're going to see other new nurses. You're going to see senior nurses. Just be kind to each other, because what we do is hard. We're taking on other people's traumas every day. And if we aren't kind to each other, it's just even harder. So,
right?
Yeah.
Why make a hard job harder?
Exactly. So it's already stressful and you're having trouble leaving it at the door. Make it easier on each other. Be good to each other. Support each other. When things are hard, just be good to each other. And I think we miss out on that a lot, because it's easy when you're irritated by all that's going on to snap at each other. I've been there, done that. It takes a little bit extra to be nice. But I think it goes a long way towards unit morale and how you feel about yourself when you go home. If we could all just
absolutely
work a little harder at being nice to each other. And that goes for me too. But
I like that. That's good. That's good advice.
3 things to forget. 3 things to forget. First one I would have to say is the doctor is not always right.
They're not?
No. shockingly.
What are you saying?
Yeah, I know.
But they're a doctor.
But they're human. They're fallible.
Good point.
And they are
Good point.
just as stressed and overworked. And just like nurses, I would say most of them are good people and wanting to do good things. And it's our job to question and do the right thing by our patients. So if you don't think something's right, you need to question the doctor. And I know it's awkward and I know it's hard, especially when you're a new nurse, because I've been there, done that. And it's still hard sometimes when I know that physician is not a nice person.
Yeah.
But at the end of the day, my first obligation is to my patient. And I will question, even if it means getting yelled at. And that's where hopefully my 3 things to remember comes into play, and your other nurses are going to support you in that.
It's important.
In that moment,
it's important to. Yeah, it's important for them to support you.
Yeah.
When you're doing that, when you're going up against the doctor and saying, "Hey, wait a minute."
Mm-hmm. And there's ways to go about it, though I've learned over the years to not just be like, "Hey, you're wrong," And I can pull that off with some docs, and some docs I can't, But you gotta be able to stand up for your patient and stand up for yourself when you know that something's not right. So don't always think that the doctor's right. Forget that word.
Absolutely.
Let's see. What else? I guess I don't know what they teach in nursing school nowadays. It's been a minute for me, I'll be honest.
Understand.
But when I was in nursing school, it was kind of shoved down your throat that the basis for all nursing was having a very strong background in med-surg. And while I don't discredit that 100%, I think that you can forget the notion that the only way to become a good nurse is to start in the med-surg unit. I think you can start anywhere.
A little controversial, but I like it.
And I am a nurse who started in med-surg, sort of. Because technically I was considered a med-surg nurse, even though my first year of nursing was spent in Iraq. I didn't become an ER nurse for a year, technically.
That's like med-surg times 200,
right?
Maybe.
And it might be a steeper learning curve. And you could say that maybe I lack some of the traditional traits of a nurse. People who know me would probably attest to that. But I don't think that has made me any less of a good ER nurse because I don't have the traditional med-surg strengths. I think that if you have a strong enough commitment to learning, commitment to being the best nurse that you can be, you can start from anywhere that fulfills you as a nurse, and become a good ER nurse. I personally don't believe, at least for me and my personality, and I think other certain personalities can start in the ER and be successful. But that's my own personal opinion.
I agree.
This part's harder than I thought it would be. I guess this is just like a general rule for life in general, not just nursing, but especially nursing in ER because it's difficult and people are nasty. But just forget all the bad. Try to take home the good. And when the bad isn't something that means you have to change your practice, then it just needs to roll off and you need to forget it. Shake it off and go on. You just got to shake it off and drive on. It's going to be better the next day. I guess.
Ain't that the truth? There's always next shift.
Exactly. Right. And you just got to forget the bad and hold on to the positive and move on.
Yep.
So.
Well, that's all my questions.
Okay.
That wasn't too bad, was it?
No, not at all. Not at all.
Hopefully that was fun.
Yeah.
I can't thank you enough for doing this
Absolutely.
with me. This has been a lot of fun.
Good. Yeah, that's good.
It's been a lot of fun to hear your answers and to hear your stories.
Yeah,
So.
it's funny to, especially how I act now, to think about how I was back then.
Like, do you think the future you would, or do you think the past you would look at the future you, or look at the current you and go, dude, what happened? What's going on?
Absolutely. I'm a totally different person.
Yeah.
I mean, I still have some of the cocky swagger that I kind of had. But there was one other story that I just thought about that I was like, I wasn't sure if it would be as applicable. This one's a little harder for me. It was my first year in nursing, ER nursing, after I got back from Iraq. And they dumped this kid off at the door. And it's Saturday morning. He looks like he's hungover, right? I'm still in the Army at the time. And at the time, we allowed our medics to triage everybody. It's a little 6-bed ER, one nurse, a couple of medics. The medics triaged the guy, put him in a bed. I hadn't even examined him yet because I trusted my medic. And that's a good thing, but I also didn't do an assessment on the guy. Doc saw him. She didn't tell me anything. He goes down to X-ray. X-ray tech calls me down and says, he's saying he can't breathe. And he looks like he's having an anxiety attack. I throw him in the wheelchair, bring him back. We put him in the bed. 2 minutes later, pink frothy sputum, just foaming at the mouth.
Oh my.
Yeah. He died. We couldn't intubate him. The kid's 19.
Holy cow.
And I never once laid hands on the kid. And I told him, if you can talk, you can breathe. Yeah. And that day, shit changed for Sarah. And well, I still feel like I'm cocky. I certainly got it backed up by a lot more frickin' practice and a lot more hands-on with my patients.
I bet.
And so I feel like I'm a little bit the same, but I think I back it up with a lot different stuff nowadays than I used to. So
I bet.
That one's a hard one for me. That was a hard one. I think it really makes you realize that why you can like trust and depend on your staff. You can't know until you put your hands on your patient.
It's trust but verify.
Exactly.
I'm anytime I'm working in the emergency department, I'm like, oh, hey, we just put a new patient in your bed. They look fine. They look great. And you're like, I'm just gonna go lay eyes on them, just real quick.
Yep.
I was telling somebody the story the other day. We were at the hospital where I work at now. We had a code, and everyone was very busy with the code. And my role was not direct care. I'm kind of on the periphery, kind of watching and kind of helping the families and working with that kind of stuff. And we were there, and everyone's working, and the secretary comes up to me and goes, "Hey, we just had a 90-year-old with syncope check in up front." And I'm like, "Huh?" Yeah. She's like, "Yeah, 91 years old with syncope." And I'm like, I look at my watch. It's like 2 a.m. I'm like, okay, 91-year-olds don't come to the emergency department at 2 o'clock in the morning with syncope.
Right, that doesn't make sense.
Very often. That doesn't make a whole lot of sense. So I was like, all right, well, I'm going to go lay eyes on that patient and make sure they're doing okay. Yeah. So I stopped what I was doing. I wasn't in direct patient contact. So I kind of walk over there, walk out to the lobby. This woman's sitting in a wheelchair in the lobby. She's got her family members there with her. And I look at her and I'm like, "Hi, how you doing? What's going on? I see that you were, maybe you'd passed out." And they're like, "Yeah, she just doesn't seem herself. She seems, like she's not feeling that well." I'm like, "Okay, well, let me just check a couple things." And I'm like, "Here, let me check her pulse." So we check her pulse. Pulse is fine. She looks okay. She's got nice, good, equal grip strength. She overall looks pretty good.
Yeah.
I mean, she doesn't look bad at all. So I'm like, well, let me just do a quick set of vital signs. So I do a quick set of vital signs. Vital signs are fine. I'm like, all right, we'll be here to triage you in a little while. but it's one of those. I just want to lay eyes on this person and be like, okay, because the last thing I need is a 91-year-old dead woman in my lobby. That's just a lot of paperwork. So, but again, you're like, let me just lay eyes on the patient. because that's going to tell me what I need to know.
Right. Yeah, yep. Unfortunately, hard lessons learned. Not that I could have changed anything, but still,
Yeah. Yeah, not that it would change the outcome, but
No.
you would have, probably had better documentation and, felt
just
better about it.
In general, felt better about like myself in general as a nurse instead of just sitting there like whatever. But anyway.
Yeah. Holy cow. And then at some point you're going to be a nurse practitioner and you're going to have a whole new set of stories.
Oh, God. Hopefully they don't involve anyone dying.
Well, hopefully not.
Yeah, hopefully they don't kill anybody.
Hopefully
that would
not.
be good.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.
Damn it, they're mowing outside. Motherfuckers.
Oh, yeah, I can totally hear it.
I know. God damn it. Let's just talk for a minute and see if it goes away. And then I got to try to sleep through this too.
I know,
so
right?
hopefully they're not going to be doing this all day.
Dear God.
Hey. Stop. One disadvantage of having the dogs here. The dog's always right. The dog's always here. She's always here. And sometimes she shows up on the podcast. What are you going to do?